Hello, welcome to the pregnancy rehabilitation course that is being offered online. I'm really excited that we are able to convert this into an online version. I think that's going to continue to be a valuable option for many participants in the future. And today we're going to start with an overview of pregnancy as one of the preview videos prior to the online portion. So I'm going to go ahead and share my screen so that you guys can view the PowerPoint with me, which should also be in your course manual. So let's get started. All right, so as I said, we're starting with an overview of the pregnant client. So this will just be an overview of the trimesters, of what goes into some of the medical side of testing, just some brief overview, and then also of labor and birth itself. So I like to start with just talking about the diversity of people who attend the pregnancy and postpartum courses. We have a variety of therapists and therapy assistants, nurses, midwives. We have other rehabilitation professionals. We have even had some OB-GYNs and other physicians in our courses. And so I just like to point out the diversity in training and in licensure of people who attend the courses, but then also differences in your practice settings. So we have many people who practice in outpatient settings, but then we also have people who come in with primarily rehabilitation and acute care settings within the hospital. And then we also have people who practice primarily in home health. And in these settings, while we don't traditionally think of working with pregnant patients in those settings, these are definitely areas where we can definitely really help pregnant women by adding these into our practices. And so we get many participants who are looking to do that. And then when we look at some of our specific experiences when working in the clinic, we do have many participants who have orthopedic experience, especially those in the outpatient setting. We often have a handful or a couple of people who have very intense manual therapy training and lots of manual therapy experience, but many people do not. We do have participants oftentimes who have some degree of pelvic health therapy work and training or experience. And then we have many participants who've never had any experience in the pelvic health realm. And then we also occasionally have people who have a focus in neuro rehab and neuro training. And so just being mindful of our varied professional experiences. But then you'll notice this last box in the bottom right corner. There's also a variety of personal experiences of people coming into the courses. So we'll have many people who either they themselves or a partner or someone that they're close to has had a vaginal or a cesarean birth, or who has been pregnant, or who is currently pregnant, maybe for the first time. And then we have many people who've never had any of these experiences or not had someone close to them in their life who's had this experience that they've witnessed up close. And so just being mindful of what I think is so great about this online version of the course is that I feel that a lot of participants are going to be able to come to sort of a more level playing grounds when we come to the online interactive portion of the course, when we get to the live portion. So those of you who have more experience in certain areas, you can move a little more quickly through this material. But those of you who don't have experience in certain areas, you might take a little more time to review this material and maybe even do a little more research on your own if you desire in preparing for the live online version. Not necessary to do additional seeking out on your own, but you could do that if you desired. All right, so we'll start with a little introduction to the perinatal course series. So we have pregnancy rehabilitation, postpartum rehabilitation, and then we also have special topics. And these courses will each have a little bit of intentional redundancy between them of some of the topics that are discussed. But when there is redundancy, there will be an intentional focus on how that differs within the pregnant versus the postpartum versus a special population. So just to give an example, with pelvic girdle pain, some of the treatments that we use in postpartum may not be as appropriate in pregnancy, or it may present a little differently. There might be some different challenges versus someone with pelvic girdle pain who's in a high-risk pregnancy and has movement restrictions from their attending OB-GYN. And so we really try to keep the emphasis within that course topic, and also knowing that there are many topics covered in the 3 courses that are not covered in the others. And so if you were to attend all 3 courses, hopefully you would feel that you got valuable material from each one that could stand on its own. So it's always nice to start with a little case that illustrates why we want to do training specifically in thinking about our pregnant and postpartum patients. And so if you're attending this course, you probably already have some thoughts in mind about why you need to do that. But I always think it's nice to just take a moment to think about this. So here we have a woman who is age 28. Her presentation is G1P0, so that means gravida 1. So she has been pregnant or is pregnant 1 time. And para, meaning the number of live births that she's had, so P0. So G1P0 could mean that she has had a miscarriage in the past, that she's been pregnant 1 time with 0 live births. But in this scenario, what this means is that she is currently pregnant for the first time, but has not given birth yet. So she is at G1P0, and she is presenting with low back pain. So our usual exam and treatment strategies, a lot of these components are still going to apply to our pregnant patient. So we're still going to be looking at what has her progression of symptoms been, what seems to make her symptoms worse, what makes them better, what's the quality of her pain, what are her pain levels, does the pain seem to come on with certain time pattern of the day, and then what activities are being affected. So this is kind of our usual typical status quo with seeing a patient that has low back pain. But when it comes to working with a pregnant woman, there might be some additional considerations that we are going to need to take into account. So for instance, if she's coming in with low back pain, we may need to rule out preterm labor contractions. We may have some contraindications or even just some precautions that we may want to consider for her exam. So there may be some of our usual examination testing or positioning for tests that we may want to modify or avoid or just be cautious with. Then we're going to want to know what modalities are going to be safe to use with our pregnant client. And then what conditions might be more likely in pregnancy that might not be as likely outside of pregnancy. So for instance, pelvic girdle pain is much more common in pregnancy. And so we're going to walk through a lot of these considerations throughout the course. And so this is just, this case is just intended to get you primed to be thinking about the pregnant patient and what we're going to consider with her. So the outline for the topics that we're going to discuss in this overview lecture, we're going to define fertilization and pregnancy and the different trimesters and talk about common medical testing and interventions within those trimesters. We'll also briefly talk about imaging and medications that are safe or not safe during pregnancy. And then we really want to differentiate progressive labor, which leads to birth, versus non-progressive or Braxton Hicks or false labor, as you may hear it called. We really want us as rehab professionals to be able to identify when progressive labor is occurring so that we can refer a woman appropriately. And so we'll talk about that. And then we're also going to give a brief overview of labor and birth. All right, so fertilization and pregnancy. So during ovulation, around mid-cycle, an ovum is going to be released from the ovary and it's going to travel to the fallopian tube. And if fertilization occurs, typically that's going to occur in the fallopian tube. So the sperm is going to travel through the fallopian tube, fertilize the ovum there, usually within about 12 hours of ovulation. And this becomes important when we talk about ectopic pregnancy later on. it's important that we know where that fertilization occurs for that reason. The fertilized ovum is then going to spend a couple of days traveling to the uterus. So it's kind of on a slow journey once it's been fertilized. And then about 2 to 3 days after it reaches the uterus, it's going to implant into the uterine wall. And then about 2 weeks, a little over 2 weeks later, it's going to have a functioning placenta. So the first trimester is defined as weeks 0 to 13 of pregnancy, and one feature of each of the trimesters is the location of the uterus. So in the first trimester, the uterus is still housed very safely within the bony pelvis, and it gets a lot of protection there. And this is really valuable because for a woman who doesn't realize that she's pregnant, that bony pelvis can offer a lot of protection for her uterus, just in case she's not realizing it and engaging in activities that that could maybe be more challenging for the pregnancy. So during the first trimester, a urine or blood test can be used to detect human chorionic gonadotropin, or HCG. So this is your typical urine, your urine pregnancy test, where you're going to urinate on the little stick. 70 to 80% of women will experience morning sickness in varying degrees. So it can be just mild nausea and range all the way to lots of nausea and vomiting. And it can turn into a condition called hyperemesis gravidarum. This is much rarer. This occurs in 1 to 200 out of 500, 1 out of 200 to 500 women. And this is a pretty serious condition. It's not harmful to the pregnancy so much, except that mom can become very dehydrated and malnourished because she's not able to keep in food or fluids. And so oftentimes women may even be hospitalized to get IV fluids and nutrition. Some famous examples of women who've experienced this condition, Princess Kate experienced this with, I know, at least one of her pregnancies. And then the comedian Amy Schumer, if you remember, she was hospitalized a good bit of the time during her pregnancy with this condition. And so usually the pregnancy itself turns out fine as long as mom is able to get some hydration and nutrition. Fatigue can be very significant in the first trimester. So oftentimes one of the very first symptoms is breast tenderness and then also fatigue. So mom may find that she's needing to take 2 and 3 naps a day and may just be very overwhelmed with the amount of fatigue that she's experiencing. Emotions can be just all over the map thanks to all of the hormonal changes that are happening. And we also want to consider that about 50% of pregnancies are not planned. And this becomes important because we may want to consider the headspace of the mom that we're talking to, of the woman that we're talking to, and also be mindful of maybe some of the things that we say to a pregnant patient when we're working with her for the first time. I had a participant in one course who spoke up when we talked about this, and she shared that she had an experience of greeting a new patient for the first time that was coming in for an evaluation, in which she said to the patient, "Oh, congratulations on your pregnancy." And she said, I was met with kind of this dead stare. And she said, I later learned that this was not a planned pregnancy and that this woman was experiencing some negative emotions around the pregnancy. And so she said, I had to do a little backpedaling to establish some rapport. She said, I was able to recover over time. She said, but it just really opened my eyes to the way I talk to patients about their pregnancies until I know a little bit more about where they are in their headspace. So just something for us to keep in mind. First trimester is also going to be the trimester that has the highest rate of miscarriage. So around 20% of pregnancies will miscarry. Many times women won't even know that they're pregnant when they miscarry. They will just start their cycle. Oftentimes the cycle will be a few days off, maybe a few days early or a few days late. And they'll have had a pregnancy and not know it and have miscarried and just started their cycle. And so, so that this is something also for us to be mindful of. You'll see many studies or many treatments or many, you'll very often see that things are contraindicated or precautioned against in the first trimester of pregnancy. And this is why. It's not so much because a treatment may cause a miscarriage, but because you don't want a treatment to be associated with a miscarriage that may have had nothing to do with that treatment. And so that will come up many times throughout the course where we will talk about how something may be precautioned or contraindicated in the first trimester. So the first prenatal visit of the mom to her OB-GYN or her midwife is typically going to be within the first few weeks of a positive test. And you'll notice this little ultrasound picture here in the top right corner. We can see the baby's spine. So we can see that little nugget of a baby that's here in the uterus. And at this point, mom is going to have a physical exam performed by her healthcare provider. And her weight will be taken. And this is important because we do want a baseline weight. We want to know that mom is gaining weight appropriately, that she's not getting malnourished. But we also are going to monitor weight because it can tell us a lot about conditions related to the placenta or blood pressure. That very rapid weight gains can be indicative of problems. And we'll talk some more about that later. Pelvic examinations may or may not be performed at this visit. So if mom is due for her annual examination, she may have a pelvic exam, or if the doctor feels that there's a need to perform a pelvic exam at this point. And then in addition, an annual breast exam might be done. Urine test will be performed, so we'll get some baseline measurements on whether or not there's glucose in the urine, which there likely shouldn't be in the first trimester. There's also going to be assessment for proteins to make sure that there's not any kidney or liver issues. And then ketones will be looked for in the urine, which could indicate a mom is not able to maintain adequate nutrition in the first trimester, oftentimes due to significant nausea and vomiting. So these are some urine tests that will be performed. At this point, ultrasound will date the pregnancy. Typically, the healthcare provider is going to want to time this first visit for somewhere between the 8th to 12th week of pregnancy. 8 to 12 weeks is going to provide typically the most accurate dating of a pregnancy, but it can be earlier, as early as 6 weeks pregnancy. And at this point too, there might also be a diagnosis of multiples, as ultrasound can show us if we have a couple of little fetuses in there. All right, so blood tests are performed at the first prenatal visit. So blood group and rhesus positive and negative will be assessed. So remembering that our moms who have Rh negative blood and carrying an Rh positive baby is going to need attention prior to giving birth. So she's going to need that RhoGAM shot in order to prevent problems. Hemoglobin will be assessed, so anemia can occur more easily in pregnancy, and we'll talk some more about that later. Blood counts will be assessed. Mom's immunity to rubella is going to be assessed, and if she's not immune, then there's going to be some treatment for that. And then there's also assessment for STDs. So syphilis and chlamydia can both be treated, and we want to treat those conditions before they can cause problems for the developing fetus. The blood, also at the first prenatal visit, blood test assessing for autosomal recessive disorders can be performed, and also assessing for hepatitis B and C. So in the first trimester, fetal abnormality screening is going to include the nuchal translucency test. So this is done towards the end of the first trimester. And in this test, ultrasound measurements are taken behind the posterior neck of the fetus, and the fluid behind the baby's neck is measured. So if you look in this little ultrasound picture over here, you can see the baby's head. And if you look at the posterior side of the neck, you'll see that those little yellow dots and that little NT. So that's the nuchal translucency, and they'll measure that distance. And so for babies with Down syndrome or with heart or gut abnormalities, there is oftentimes going to be an increase in extensibility of soft tissues. And with that increased flexibility of the soft tissues, more fluid can accumulate behind the neck. So this is just a screen. It doesn't tell us that the baby actually has any problems, but that screening test can indicate that some more testing may need to be performed. And oftentimes a nuchal translucency test, if it's positive, will be combined with serum screening tests, which we'll talk about in the second trimester. So the second trimester is going to be during the weeks 13 to 26 of the pregnancy. And the uterus is now moving out of the bony pelvis. And so this is why you'll see with a lot of pregnant athletes, for instance, that they will be advised to stop playing their sport when they reach the second trimester. So for instance, basketball players or anyone who can have any sort of blunt force to the abdomen with their sport. A lot of women will start to get their energy back and will start to feel really good. So for a lot of women, they'll say that the second trimester feels really magical and that they just have tons of energy and they just feel really amazing. And people are starting to know that they're pregnant. And so they just have this pregnancy glow oftentimes, and they're feeling good and they're just really happy about life. The placenta is continuing to grow, and the amniotic fluid is very important at this point for development and protection. And the second trimester is often where amniotic fluid problems will start to arise and show themselves through rapid weight gain, blood pressure problems, etc. And we'll talk more about that later on. But just being aware of that amniotic fluid at this point is becoming very important. And for a lot of women, they'll start to say they're just starting to feel a little bit of mommy brain. So they're feeling just a little forgetful about things, a little foggy on details sometimes. And there's actually evidence to show that moms' brains will shrink a little bit during pregnancy. It does come back eventually, but the mommy brain does seem to be a documented thing. So in the second trimester, prenatal visits are going to include more urine tests. There's going to continue to be assessment for protein to make sure that the kidneys and the liver are functioning well. There's going to be assessment for glucose. And at this point in pregnancy, some women may have glucose in the urine, even if they don't have gestational diabetes. But the urine test will serve as a screen to determine if more testing needs to be done to determine if a woman has gestational diabetes. And this is because of the transporters for glucose that are within the kidneys. Because they become very overloaded in pregnancy, glucose can end up being in the urine even for a woman who's in a healthy pregnancy without gestational diabetes. So something to be aware of, that a woman can have glucose in her urine, and we'll talk about that later on too, how that can lead to more bladder infections. Blood pressure is going to be monitored, an assessment for edema, so a little bit of dependent edema in the feet, the calves, the hands. If a woman's been standing for a while or at the end of the day, that can be pretty typical, but there is going to be observation for any excessive edema happening throughout the body, as again, that can indicate blood pressure problems and some high-risk pregnancy conditions. Fundal height will be assessed. So with fundal height, there is a measurement taken from the top of the pubic bone up to the fundal height, so the highest point on the uterus. And by about 14 weeks of gestation, the fundal height should be 14 centimeters, and that should continue at about 1 centimeter per week going on, to the end of the pregnancy, towards the end of the pregnancy. And so this is just a method that is used to assess for if the baby and the fetus is growing as it should. Doppler ultrasound is also going to be used to assess baby's heart rate. So they're looking for baby's heart rate to be in a normal range. And then maternal weight is going to continue to be monitored. So in the second trimester, we talked about the serum screening earlier that can be combined with that nuchal translucency test. So you may hear varying versions of this. So one is the triple screen, and this is where they assess for alpha fetoprotein and beta HCG and estriol. And then the quadruple screen, which is where they perform that same triple screen, plus they also assess for inhibin A. And this variety of screenings can detect various congenital anomalies and conditions. If they combine that nuchal translucency and the serum test, when we're looking at things like Down syndrome, there is a 5% false positive rate. So realizing that just because there's a positive doesn't mean that the baby actually has a condition, but there is an 85% detection rate. So that combination of tests is actually pretty good for determining if Down syndrome or other conditions are present. And then 1 in 45 women who are actually affected will have had a positive screen. So what that means is that 44 out of 45 women who have a positive screen are not affected. And I think this is very encouraging for women who do have a positive screen to know that they still have a very high chance that their baby is not affected. So just realizing that, that false positives are pretty high. So diagnostic testing, so to actually diagnose Down syndrome or other genetic disorders, chorionic villus sampling is one technique that's used. It's typically done at weeks 11 to 14, and it's not used as commonly as some other methods, which we'll talk about in a moment, but this is one technique that can be done. But an ultrasound guided needle is placed through the abdomen, through the placenta, and a little piece of placenta is biopsied, and that placenta can then be used to diagnose any genetic disorders or condition. There is some risk for miscarriage. It's small, but it's a higher risk than some other methods for diagnosing. It can also cause abnormal limb development due to that needle affecting the fetus. So more commonly used is amniocentesis. So this is considered to be a little safer than CVS. It's usually done at weeks 14 to 16, but it can be performed well into the second trimester. Again, there's an ultrasound guided needle, and this is a really nice image to show how that's performed. That the ultrasound is going to allow the physician to see where they're going, and this needle is going to be placed into the amniotic sac, and they're going to culture fetal skin cells from that amniotic fluid. So it does take a little time because they have to grow out those fetal skin cells. This will often be offered if a woman had that positive screening that we talked about, or if she's over age 35, or if she has some family history of genetic abnormalities. So these are some other diagnostic tests that can be performed. So I'm not going to really talk about those here, but just know that there are some other methods for diagnosing congenital conditions for the fetus. So the 20-week scan, so oftentimes you'll hear pregnant women say, well, I'm going for the big ultrasound, or I'm going for the big scan this week. And this is the big ultrasound. So they're talking about the 20-week scan. So this is often the one where, sometimes you'll see like a whole family going in to check out the baby and see what's happening. But with this scan, the fetal heartbeat is going to be assessed, and the physician is going to look for 4 heart chambers. So is the heart forming the way it's supposed to be? They're also going to look to make sure that the abdominal cavity and organs are forming the way that they're supposed to be. They're going to check out the head and spine. They're going to count the vertebrae and make sure that all the vertebrae are present, and look for any signs of spina bifida. They're going to look at the brain and see if there are any excessively enlarged ventricles, or look for any cyst. They're going to look at the placenta. So we want the placenta to be positioned ideally high up on the uterine wall and not down near the cervix. So this is when they're going to start to look for things like placenta previa or a placenta accreta, where the placenta is growing into the uterine wall abnormally. They're also going to measure the amniotic fluid volume, so they want to make sure that there is enough, but also not too much amniotic fluid. And at this point, we can determine the baby's sex by observing the genitalia. So in the third trimester, we're now at weeks 26 to 40 of pregnancy, and the uterus has moved from the pelvis to the abdomen, and now it is pushing into the diaphragm. So this is when I say that the uterus becomes partially a thoracic organ. So women will experience shortness of breath. They start to feel fatigued again because their body is at a point where a lot of the energy reserves are now going to fetal development. And so mom is tired, she's short of breath. It's very likely that she may have some edema. And again, as I mentioned, some swelling in the hands, the feet. At the end of the day, if the swelling goes away when she props her feet up, that's usually not a problem. It's usually just an overload on the lymphatic system that is causing her to have that swelling. But if she has excessive edema or very sudden swelling, this can indicate problems. At this point, very vital fetal lung development is occurring in the third trimester. And some very common symptoms that women may experience that may just be air quotes, typical pregnancy symptoms. Women may experience urinary frequency because of all the fluid their body is processing and the weight of that gravid uterus on their bladder. They may experience vaginal infections due to some of the changes in the pH and vaginal secretions in pregnancy. They may have more headaches, itching skin, especially on that growing belly. They may experience more hemorrhoids, leg cramps, acid reflux, and those are just some of the symptoms, but the third trimester is when these tend to worsen. So prenatal visits in the third trimester. In an uncomplicated pregnancy, moms will have monthly checkups up until 32 weeks, and then they will become more frequent after that. Glucose tolerance screening is going to be done at the end of that second and beginning of the third trimester. And if that glucose tolerance screen is abnormal, then a glucose tolerance test is going to be done to determine if mom has gestational diabetes. Again, at 28 weeks, they're continuing to assess hemoglobin, so observing for any anemia for mom. Again, looking for antibodies if there is an Rh positive fetus. Still assessing the urine glucose, blood pressure, because they want to rule out any problems like preeclampsia, and continuing to assess the fetal heartbeat to make sure that baby is developing and thriving as the baby should be. And then continuing to assess the fetal height and the fetal position. And now fetal position is going to start to be of interest due to preparation for labor and birth. And so this is, if you want to read more about medical imaging in pregnancy, this is a committee opinion that was put out by ACOG, or the American College of Obstetricians and Gynecologists, in October of 2017. And the information that we have in this lecture came from this committee opinion. All right, so what does ACOG say? So they looked at the evidence and they determined that there is not risk associated with ultrasonography or with MRI, but that these should be used prudently for assessing various conditions. I have seen some recommendations for limiting MRI use in the first trimester, again, because of that higher risk of miscarriage being in the first trimester, not because MRI itself can actually cause the miscarriage. So just something to be mindful of. You may hear someone say that they were told they couldn't get an MRI because they were in the first trimester, and that might be why. There's also discussion about limiting the use of gadolinium contrast with MRI because it can have some risk to the fetus. So this hasn't been demonstrated fully in the literature, but there is some possible risk that's been seen. Radiographs, so having X-ray, CT scans, and nuclear medicine imaging are typically considered to be low risk to the fetus. They just want to limit that exposure to the fetus. So it can be used if needed, but there is a desire to limit that exposure to the fetus. So that is it on imaging, and that is the summary from ACOG. Medication use in pregnancy. So when we are looking at prescription medications, the old labeling system of ABCDX is in the process of being phased out. And as of June 2015, there was a new system of this PLLR, Pregnancy and Lactation Labeling Rule. And each of these rules have a narrative summary, and this is in the process of being phased in. One thing to keep in mind is that the old labeling system currently still applies to over-the-counter medications. So you won't see that change. So this is going to apply more to prescription medications. And so if you're not familiar with the old pregnancy medication labeling categories, category A means that there have been quite a few well-controlled human studies that have demonstrated that there's no risk to the fetus in the first trimester. And then if you continue to read through the categories, you'll see that the risk goes higher. So oftentimes, medications in the category of A and B will often be recommended or prescribed to women. C starts to get a little riskier, and so there's going to be some weighing of whether or not that the benefits would outweigh the potential risk. D, probably going to steer clear, but again, there may be some rare occasions where the benefits outweigh the risk. And then if a drug is labeled as X, they're typically never going to prescribe that medication because there are definitely some teratogenic effects to the fetus that outweigh the benefits of using that medication. So the new PLLR categories, there is discussion that these eliminate some of the risk of the letter labeling being a little too simple. So the idea here is that the PLLR categories really is going to help a physician or other healthcare provider to really have a conversation with a woman about whether or not they want to prescribe a medication. And so you'll notice they have these different sections associated. So in the medications labeling, they'll have this 8.1 pregnancy narrative, and then they'll have an 8.2 lactation narrative where they talk about any risk or considerations with a lactating woman. And then 8.3 females and males of reproduction potential. So now they're starting to include men in the labeling. So how is this medication also going to affect fertility? And so definitely when you read through these sections, they're a little more descriptive. All right, so now we are transitioning into an overview of labor and birth. So we get to the end of the third trimester, and ideally this is where we're heading. And just briefly here, I want to introduce the thought about some of the language that we use with our patients, and that we kind of want to steer away to some degree from the word delivery. And so we'll talk about that a little bit, but we really want to think about labor and birth. And so with that discussion, and it's such a hard thing to do. It's so quick, it's so easy, it's just so natural to flow off our tongue is labor and delivery. You know, it's such an ingrained term, but this is a discussion that I'm seeing and hearing more and more kind of in the pregnancy world and the doula world and the birth midwifing world of people talking about using the term birth, which is a much more empowering term when you think about the mom who's giving birth rather than the word delivery. And one of my favorite stories to tell when I teach the course is having a friend who worked in a birthing center, and she would very often talk about, well, the delivery of the baby, and her one of the midwives that worked with her was constantly correcting her and saying, Amber, you got to quit saying delivery, you got to say birth. And so one day the midwife said to her, Amber, you birth a baby, you deliver a pizza. And I just really love that. And so I don't want to shame anyone for using the word delivery. So please don't think I'm doing that. But just to really think about the way that we can empower our patients, and to think about how the word birth indicates. So if a woman births a baby, now her healthcare provider team is in the supporting role, and she's the one performing the kind of the star role, and not to downplay the role of the healthcare providers involved in labor and birth, because certainly they are crucial and critical and absolutely necessary, and also star players. But to really think about where we put the emphasis when we say that the baby was delivered, that now mom becomes sort of a passive participant just by virtue of the language we use. And so I really love to have us thinking about ways that we can empower our moms with the language, just such a simple thing, the language that we use. And so in our clinic, we've gone through all of our paperwork and taken out the word delivery. And we'll talk a little bit too about C-section. We have also taken out C-section and changed it to cesarean birth, because again, it just really changes the empowering and the emphasis for the mom. So that was a long, winding discussion there that I just gave you. But I hope that it will give you some food for thought. And I hope that it's something for you, if you've ever given birth or if you're about to give birth, that it's something that makes you feel a little empowered just to think about your labor and your birth and that kind of terminology. Okay, so labor preparations. So mom's body is going to start preparing for labor several weeks before that, quote, true labor onset. And so moms will experience something called lightning. So this is what you'll often hear traditionally being referred to as the baby has dropped. So when the baby drops, that's the baby is beginning to move down into the pelvis to prepare for birth. Assuming the baby is head down, then that's going to be the fetal head. And they call it lightening because the baby is finally moving out of that diaphragm, and mom can often breathe a little bit better. And her lower abdomen will suddenly get enlarged. And so that's something that you may hear women sometimes say is like, oh, her baby dropped, you can see it. Braxton Hicks contractions will start occurring more frequently in these last couple of weeks. And this is the uterus's way of preparing for birth. So the uterus starts practicing little contractions, and oftentimes it's going to be in different quarters or different components of the uterus. So typically the whole uterus won't contract at the same time, but it can with the Braxton Hicks. But the key with the Braxton Hicks is that there's not progressive changes of the cervix at this point. The cervix will start to efface, so there will start to be some softening and thinning. And as we get closer to birth, there might be loss of the mucus plug, and we'll talk more about the mucus plug later. But that's that little plug that's going to cover the cervix, which is very protective of preventing infection inside the uterus during pregnancy. And that mucus plug, it looks like a kind of a bloody mucus plug, and it looks like a little menstrual cycle when it's lost, a little short. It doesn't last for long, but that's what will happen. All right, so this is just a really nice image that shows kind of, if you look on the left, and we can see the liver here at the top here, just below the breathing diaphragm, and the heart and the lungs. The stomach, you can see how open it is. The intestines have lots of room to do their job. You can see the uterus just gently resting above the bladder, and the bladder has plenty of room. The intestines have plenty of room. And then we look to the right and look at how squished that stomach is. Look how little space the intestines have to function. Look at our poor little bladder getting squished between our pubic bone and the uterus. We can't see it as much here, but definitely some compression on the rectum. And so just really appreciating how this space occupying component of pregnancy, how much it's going to impact every single organ in the body, just by nature of the physical and mechanical compression of those varying organs. And so just really appreciating that as we look here. Okay, so non-progressive labor, or you might hear it called false labor or Braxton Hicks contractions. So these will happen up to 2 months towards the end of pregnancy typically. And these are irregular contractions. Although they start to become more like, so there's a little bit of a gray area where the non-progressive labor contractions start to turn into progressive labor contractions. And again, this is the uterus kind of getting a little workout in. It's kind of prepping for the big day. It's, you know, flexing its muscles. It's doing its weight training. But the big thing with non-progressive labor is that it's not going to be associated with changes in the cervix that lead to birth. So the cervix is not going to dilate. There might be a small amount of effacement that happens, but not a significant amount. And so once that cervix starts changing, that is when labor before 37 weeks would be considered preterm labor. But at this point, if there's no changes in the cervix, and typically mom can lie down and rest and the contractions go away, that would be considered non-progressive labor. Totally normal to happen, but we don't want it causing cervix changes too early. With progressive labor, this is the onset of true labor. And with true labor, we're going to have those rapid changes in the cervix that are going to result in birthing of the baby. And so the 4 stages, this is just a little summary slide. We'll go more over each of these. The first stage is going to involve both latent and active phases where we get those cervix changes. The second stage is going to start with full cervical dilation and result in birth of the fetus. The third stage is when the placenta is going to be delivered and any perineal repair might occur. And then the fourth stage is when the mom is being monitored in the early postpartum after the birth. And this is just a nice little summary slide of the difference between progressive and non-progressive labor. So with progressive labor, contractions happen at regular intervals. And so they may be every 5 minutes or every 3 minutes. With non-progressive, these are not occurring at regular intervals. So there may be a contraction here and there, and it's not that every 3 minutes, every 5 minutes, every 2 minutes. You can't time these and get a pattern. With progressive, the intervals are going to gradually get shorter. So they may start out every 5 minutes, and then the next thing you know, they're every 3 minutes and every 2 minutes. Again, there's no pattern to the non-progressive. With progressive, the contractions are going to increase in their length. So each contraction will last longer and it will become more intense. With progressive labor, there can be discomfort in the low back or the low abdomen. With non-progressive, typically there's just discomfort in the abdomen, not usually in the low back also. For progressive labor, activity is not going to change the contractions. So it doesn't matter if mom lies down, if she gets up and walks around, if she moves, its activity is not going to make the contractions get worse or go away. It's not going to have an effect either way. With non-progressive labor, intensity can be affected by activity. So for instance, if mom is experiencing some Braxton Hicks contractions, if she lies down and drinks some water, oftentimes those contractions may go away or may become way less tense. Again, with progressive labor, cervical dilation and effacement are occurring, and that can only be assessed with a vaginal exam by a woman's midwife or nurse practitioner or her OB-GYN, someone who is trained to do that. So we wouldn't be able to know if that's happening as a rehab professional, but that is something that would have to be assessed by her doctor or other healthcare provider. And then with non-progressive labor, no changes in the cervix. And then again, with progressive labor, taking a warm bath, a warm shower, getting rest, That's not going to change the contractions, but with non-progressive labor, those things could actually ease the contractions. So cervical effacement and dilation. Dilation, you might also hear it called dilatation. So this is the amount of opening of the cervix measured by centimeters or finger breadths. So if we look over here at the fetal head, we can see the cervix here, it's probably fully dilated. So you can see one edge on either side of the crown of the fetal head, that there is probably a full dilation or a complete opening of that cervix. Effacement is the thinning of the cervix. And so you remember in that picture a few slides back, I'm going to go back to this picture for a moment. So you can see here the cervix is closed. So it's closed up. There would be a mucus plug within that space that you can see there. But the cervix is closed and you can see it's nice and thick. So dilation is the opening going from that sort of pinhole opening to wider and wider and wider until it's a 10 centimeter circle. And then effacement is going to be where this thickness in the cervix becomes thin. So it goes from being kind of a fat donut to being sort of a thin pancake. And we can see here how this becomes sort of that thin pancake and it becomes very wide in the opening. And so you'll hear it expressed as centimeters and percentages. So 4 centimeters dilated and 75% effaced is an example of what you would hear. When a woman is fully dilated and fully effaced, she would be at 10 centimeters dilation and 100% effaced. So loss of the mucus plug, so we mentioned this. So this is a thick mucousy component that has a little bit of blood tinge to it, and this occurs as the cervix softens. This can occur right when labor is starting or after it's starting, or it can happen a week or two before labor starts. Membrane rupture. So the amniotic membrane will often rupture on its own from the contractions pushing the fetal head against the amniotic membrane. But it can also be assisted with what's called stripping the membranes and with a device called the amni hook. So they can reach in and actually cause the membranes to rupture. If the membrane ruptures too early, there can be a risk of infection. So oftentimes, once the membranes have ruptured, oftentimes they'll want the baby to be delivered within 24 hours to prevent infection. So just a little summary of the stages of labor. So the first stage is where we have progressive contractions and those cervix changes. The second stage, again, birth of the baby. Third, birth of the placenta. And then fourth stage, maternal recovery. So we're going to go through those. So the first stage is going to begin with that progressive labor onset. It will often, on average, last 12 to 19 hours, but it can be much less than that, and it can be much more than that. It's going to be longer in premi-gravid women or women who are giving birth for the first time, so in their first pregnancy. And then this first stage will be affected by sedation and by stress. So the first stage of labor can be slowed down if a woman is very stressed or if sedation is introduced too soon. And so that's just something to consider. Or if in the labor state, in the later portions of the first stage of labor, sedation can sometimes be helpful because it can actually decrease mom's stress and her body can actually progress a little bit better with labor. And so something to think about is timing of sedation can be impactful on the stages of labor. Within that first stage of labor, transition will occur. And this is that when the cervix dilates from 8 to 10 centimeters, transition tends to be pretty intense. And this is when a lot of women will feel a little bit wiggy during birth. And the first stage of labor is divided into latent or early phase, the latent or early phase, which is going to be about 0 to 4 centimeters dilation, active, which is about 4 to 6 centimeters of dilation, and then transition from that 8 to 10. And so the contractions are becoming more intense and more frequent as you progress through those phases. The first stage of labor ends when the cervix is fully dilated, and that's the start of the second stage of labor. So the latent phase, so at this point, the cervix has become fully effaced. And again, as I mentioned, dilation up to 4 centimeters. And this is going to be a little bit longer, again, in first-time moms. And contractions are pretty regular, but mild, occurring every 10 to 30 minutes, increasing up to 5 to 7 minutes in frequency, and lasting anywhere from 30 to 40 seconds each time. In the active phase, the cervix is going to dilate from 4 to 7 centimeters, and the contractions and the pain intensity are becoming a little more intense. Contractions are now 2 to 3 minutes apart, and now they're lasting for a full minute. So they're happening for a longer time, and they're coming more frequently, and the fetus is going to continue to descend into the pelvis. And then that transitional phase, contractions now are occurring every 1.5 to 2 minutes and lasting for 60 to 90 seconds. So mom isn't getting a whole lot of a break in between contractions, and they're lasting a really long time. And so this is where women may be tired and restless and just feeling a little bit wiggy, is oftentimes what you'll hear folks report. So in the first stage, women can walk around or get in sideline or other positions. Depends a lot on facility. So when we're advising women on labor and birthing positions, one thing that we might want to have them do is ask questions about what the birthing center or facility or hospital will allow them to do once they are in the hospital. So some places, once a woman is on monitoring, they don't really want her leaving the room or getting up and moving around too much. And so you'll want to ask about that. It can also vary too based on getting having an epidural. So some places won't allow women to move around too much or leave the room or get out of bed if she has an epidural. So something you'd want to ask about. So uterine contractions and fetal heart rate are typically going to be regularly monitored. And if a woman's in a high-risk pregnancy, those may be continuously monitored. Vaginal exams may be limited to help reduce infection risk. Oral fluids may be limited. Food intake is often going to be limited. And this is in case mom needs to suddenly be sedated. They don't want her to aspirate if they have to do that. And then they're going to be checking mom's heart rate, blood pressure, respiratory rate, and temperature. So the second stage of labor is going to start with full cervix dilation, and mom is going to start to feel some urges to bear down when she has contractions. So she'll naturally feel a need to push when those contractions are pushing the baby out. And one thing to be just kind of mindful of is that ideally the uterus is doing the bulk of the work of pushing that baby out. Yes, mom is working hard too, but the uterus really should be doing a lot of the work and guiding mom on when she needs to bear down. This is typically, again, going to be a little bit longer for first-time pregnant moms, so it can last up to 3 hours on average. Again, this is an average. These stages can be much shorter or even much longer. Again, contractions are lasting 1 minute to 90 seconds and occurring every 1.5 to 2 minutes. So they're still happening pretty frequently. And then the fetus is going to continue until the head reaches the pelvic floor. And as the fetal head begins to move through the perineum, that fetal head will result in crowning. So crowning is when that fetal head is coming out of the vaginal opening. And the second stage will end with the birth of the baby. So episiotomies are typically going to be performed during crowning if they're performed. This is a cut through the perineum that goes through that superficial skin and superficial musculature at the perineal site. It can occur midline or mediolateral. We'll have an image of that in a moment. It's recommended by ACOG that these are not performed routinely. but there are some reasons to perform them. So if a woman, if it seems that she might tear into her clitoral hood or her clitoris, for instance, a physician may perform an episiotomy to guide tearing to go in a different direction. And these are, by definition, a grade 2 perineal laceration. And so this just shows the midline or the mediolateral approach. So midline is where the cut is going from the posterior side of the vagina, vaginal opening rather, and down through that superficial muscle towards the anus. That arrow is going a little bit long. It should be going all the way to the anal sphincter, but that can lead to tearing, as you can imagine, into the anal sphincter. The mediolateral cut is going again from the bottom of the vaginal opening, and you can see out towards the side. And again, they're cutting through those small superficial muscles. Midline is very traditionally done in the United States. It tends to have less post-op pain, but the healing tends to not be as positive as far as being preventative of incontinence and things of that nature. The mediolateral, where it's running obliquely off to the side, that's more traditionally used in Europe. There tends to be a little more pain post-birth, but the healing tends to be a little more positive as far as function of the pelvic floor muscles later on. And this is just showing some different types of tearing. So you can see this top image, there's tearing into the anal sphincter. So that would be a grade 3. So if tearing goes through the superficial fat and skin and those superficial muscles, then that's a grade 2. If it goes just through the skin, that's a grade 1. But once you get into that anal sphincter, as you can see here on that top image, that's a grade 3. If there's tearing up into the rectal mucosa, which you can't really see in any of these pictures here, that would be a grade 4. So those are the 4 grades. But then you can also have this occult tearing. So you can see that if the skin were intact on these lower pictures, that you might think this is a grade 1 or even a grade 2 tear, but you can see this tearing of the levator ani muscles. And there's not a lot of research right now that tells us what happens to those pelvic muscles and how well they heal. And we suspect that this can lead to a lot of issues long term. So just being mindful that what we see on the surface is not always indicative of what's going on underneath that skin. So then the third stage of labor, so this is after the baby is born. So the baby is now out, and now the placenta has to come out. And so this usually occurs within that first 30 minutes after birth. And this might occur with the uterus contracting. And as the uterus contracts, what it's going to do is it's going to shear off the vasculature between the placenta and the uterine wall. And that prevents any hemorrhaging in the postpartum. And then that allows the placenta to be birthed out through the birth canal. The healthcare providers involved in the birth may also provide a little traction on the umbilical cord to assist in that removal, and a little pressure on mom's abdomen to help facilitate this movement out. But ideally, we want those uterine contractions being what causes that separation of the placenta from the uterine wall. So the fourth stage, so this is where mom is being monitored for her physiologic adjustment. So there's going to be careful monitoring of mom's heart rate, her blood pressure, her respiratory rate. We want to make sure that she doesn't have any signs or symptoms of hemorrhaging or other issues. And so they'll usually monitor for about 4, maybe 6 hours after birth. So we're going to talk a little bit about analgesics and anesthetics used in labor and birth. So analgesics or painkillers can be given in the first stage. These relieve pain. They can have a calming effect, but without loss of muscle function. They do act systemically. Opioids can be given via IV or injected into the muscle tissue. There can be some side effects for mom and for the baby, so just good to be aware of. Nitrous oxide or laughing gas, this can also be used through a mask. Epidural anesthesia, these can be given once a mom's in active labor. They usually like to wait till mom is at least 4 to 5 centimeters dilated, oftentimes by about 6 centimeters dilated, and having regular contractions, but they want to perform an epidural before mom begins to crown. So there does become a point where an epidural is no longer appropriate to give. So there is a catheter that's injected into an epidural space. It takes about 10 to 15 minutes to insert, and these provide pain relief, but they also affect muscle function. If it's a very low dose, then you might hear this called a walking epidural, where mom can actually move her legs. She might be even able to stand up and get out of bed and walk around a little bit, if her facility where she's birthing will let her. She may still feel an urge to push, but if she lacks that sensation, she might need coaching during her contractions to push. And then this little image shows that epidural needle, you can see, is placed into this epidural space, and the anesthetic is provided through that needle. So there are some potential side effects with epidural anesthesia. Birth sometimes can take a little bit longer, just because it does affect mom's strength and her sensation for pushing. Epidural anesthesia is more associated with having an assisted birth, so using vacuum or forceps. It does not increase the chance of cesarean. And then there's no long-term disadvantages reported as far as the infant is concerned. Spinal blocks, so these are similar to epidurals, but the anesthetic is injected into the subarachnoid space as opposed to the epidural space. Again, the lower half of the body is numb. These work a little bit faster than epidurals, and these are often going to be used for cesareans. Pudendal nerve blocks might be used for if there's going to be vacuum or forceps use, and this is where anesthetic is injected into the perineal tissue to hit the pudendal nerve. Okay, so to summarize, pregnancy begins with fertilization, and it's going to end with the birth of the baby. And our understanding of what happens in our trimester helps us to communicate with our patients with what's going on, helps us to understand the medical management that's happening, and it helps us in managing our patients. So, when I first started working with pregnant women, I had never been pregnant myself, and I hadn't really been that closely involved with someone having a baby. And so I had to do a lot of reading to understand what my patients meant when they said, I'm going in for my big ultrasound, or, I'm getting the triple screen done. And so just having some understanding of those things, if you're not already familiar with them, can be really helpful just in appearing knowledgeable to your patients, and also understanding what they are going through. And then knowing, having knowledge of labor and birth, it helps us in preparing our patients for giving birth, which we're going to talk about during the live course as well. So thank you guys for listening. And if you have questions, we'll have a little time to address those at the beginning of the first day, or you may be able to email me at the end of the course if you have more questions on this particular presentation. So thank you guys for listening, and hope that was helpful and informative.